The key challenges or the difficulties during the procedure would be, you're looking at anastomotic leak, gastric conduit viability, the pulmonary complications and nutritional morbidity, and it is a complex decision that you need to take, especially post-neoadjuvant therapy. So preoperative optimization is most important. Look at the nutritional support. We discussed about need for FJ, which we routinely don't do if you're planning for a definitive surgery, but see that the albumin level is more than 3 gram%, and the pulmonary function test, and preparing them even as they finish the last dose of radiotherapy, or when they finish their chemotherapy, to make them go for in situ spirometry and counseling regarding cessation of smoking and aggressive chest physiotherapy does help give us good outcomes post-operatively. So the anatomical constraints, definitely for esophagus-gastrectomy, you have a narrow thoracic inlet. You have aberrant left hepatic artery could be a difficulty. Because of prior surgery, some adhesions could be a challenge, and somebody was talking about fibrosis. So I think Funny was talking about that. So adhesions, inflammatory adhesions could be a challenge, especially post-radiotherapy. Some of these could be a challenge. So intraoperatively, what could be the challenge? The mobilization could be a challenge, especially in bulky tumors which are stuck to the surrounding structures, maybe pericardium or aorta. The involvement of the bronchial tree could be a challenge. Of course, you have a nodal disease along the recurrent laryngeal nerve that could be a challenge during the dissection. So, of course, the bleeding is much less these days with respect because of the advent of minimal invasive surgery. So, the anastomotic challenge is something that I want to stress upon. We need to do a tension-free anastomosis. The gastric conduit perfusion must be ensured, especially with the advent of ICG. We are able to do much better and understand the perfusion, and the risk of leak and strictures can be reduced with the different techniques that we have seen. The posterior stapling and the anterior. So double stapling technique with a very wide anastomosis helps us to reduce the risk of stricture. So how do you reduce what are the risk factors for leaks? Poor conduit perfusion because of poor surgical technique, tension, malnutrition, and of course some of these patients who are neoadjuvant chemo RTS given, there is also a risk factor for the same. So how do you manage the anastomotic challenges? I think cervical anastomosis, as I mentioned before, though the leak rate is high, it's very easy to manage conservatively, and often it could be just a wound issue. You can manage locally with a drainage and very less risk of mediastinitis for the cervical anastomosis. Whereas intrathoracic, for Ivor Lewis, if you look at, there is a lower rate of risk, but if at all the leak happens, it is very much dangerous because of the mediastinitis and sepsis, and it requires exploration and stent in many cases. So lymphadenectomy also can be challenging in some cases wherein you have a keynotes at difficult areas like recurrent laryngeal, I mentioned, risk to the thoracic duct also could be a challenge. So how do we overcome this? The most important fundamental thing is better preoperative imaging, better planning preoperatively. Minimal invasive options does help us to overcome these difficulties. Meticulous surgical technique without compromising on the oncological outcomes, and of course intraoperatively using some of the tools that we have, including ICG, will go a long way in reducing the risks and making these surgeries simple for us. So the port positioning for a prone position for the thoracic part of the robotic esophagectomy, I've mentioned about ICG, which we have already seen. So I just want to conclude that esophagus-gastrectomy is not just a surgery, it is a physiological reset. So the success lies in this surgery in selecting the right patient, the right approach, and respecting the anatomy of healing. So I just want to close with this statement: leak in the neck is a nuisance, leak in the chest is a catastrophe. So thank you so much for your patient hearing. Thank you.